Hi, my name is Talk Psenicny, and I'll be talking about non-rigid motion-compensated whole heart CMRA with autofocus virtual 3D INAV. 3D whole heart coronary MR angiography, or CMRA, is a promising tool for non-invasive visualization of cardiac anatomy and to assess coronary artery integrity. Despite several improvements, CMRA acquisition can suffer from residual motion and undersampling related aliasing artifacts, and remains lengthy. Different approaches have been proposed to tackle those limitations, such as stealth navigation and image navigators. 2D image navigators, or iNAVs, enable beat-to-beat translational respiratory motion correction in the foot head and right-left directions. However, beat-to-beat anterior-posterior motion is not corrected for with this approach. Here we aim to investigate the effect of autofocus-based virtual 3D INAV approach to further enable beat-to-beat anterior-posterior and intra-bin motion-corrected reconstruction. Free-breathing motion-corrected 3D whole heart CMRA acquisition framework consists of adiabatic tissue preparation, low-resolution coronal 2D image-based navigators, which are acquired to track the respiratory motion of the heart and enable 100% efficiency, and variable density Cartesian trajectory with spiral profile reordering for faster acquisition. In the first step of motion-corrected 3D whole heart CMRA reconstruction framework, the foot head and right-left motion is estimated from the 2D iNAVs. Anterior-posterior motion is then estimated with autofocus approach, assuming a linear relationship between the foot head INAV signal and AP movement of the heart. Beat-to-beat 3D translational respiratory motion is estimated. 3D non-rigid motion is then estimated from the respiratory resolved bin images and incorporated into the motion-compensated reconstruction with patch-based low-rank regularization to produce motion-free CMRA datasets. Anterior-posterior motion is assumed to be proportional to the foot head INAV signal. By correcting the data with different motion signals alpha in anterior-posterior direction, a set of translationally corrected images are obtained. The optimal scaling alpha is obtained by minimizing the localized gradient atrophy in a region of interest surrounding the left ventricle. With anterior-posterior motion estimation, the virtual 3D INAV is then used to bin and motion-correct the data. In this proof-of-concept study, the approach was tested in 5 patients with suspected cardiovascular disease scanned on 1.5 Tesla system. Imaging parameters can be observed here. Data was acquired at 1.2 isotropic resolution and average scan time of 6.1 minutes. Virtual 3D INAV-based non-rigid motion-compensated CMRA was compared against 2D INAV-based non-rigid motion-corrected and no motion-corrected images. On the figure, we observe some slight improvement in the delineation of the coronary arteries with our proposed virtual 3D INAV-based non-rigid motion-compensated reconstruction in comparison to the 2D INAV-based approach, as pointed out with the arrows. We can also observe some slight reduction of remaining respiratory motion artifacts in some subjects, as shown on this figure. The arrows are pointing to the areas which improve due to our proposed approach. We can observe improvements in sharpness and detail. To investigate further, we applied our virtual 3D INAV approach to the 3D whole heart, water-fed, high-resolution late gadolinium enhanced cardiovascular MR imaging data. The dual echo 3D data was acquired applying inversion recovery preparation pulses, each heartbeat, to note the viable myocardium signal. A low-resolution coronal 2D dual echo INAV was acquired immediately before the 3D dual echo acquisition for respiratory motion tracking and to achieve 100% scan efficiency. 3D data was acquired following an undersampled variable density golden step Cartesian trajectory with spiral profile order sampling for faster acquisition. 2D INAVs are used to estimate the foot head and right-left respiratory motion of the heart during the acquisition by tracking a manually selected rectangular template. Anterior-posterior motion is estimated with autofocus approach. Beat-to-beat 3D translational respiratory motion is estimated. 3D deformation fields are estimated using non-rigid image registration of the respiratory resolved bin images and incorporated into the motion-compensated reconstruction with patch-based low-rank regularization to produce motion-free images. The dual echo images are used to generate undersampled motion-compensated water-fed LGE images. We investigated further in 5 patients with suspected cardiovascular disease scanned on 1.5 Tesla system. Imaging parameters can be observed here. 1.3 isotropic resolution was used, and average scan time was 7.3 minutes. Virtual 3D INAV-based non-rigid motion-compensated approach was compared against 2D INAV-based non-rigid motion-corrected and no motion-corrected images. Slight improvements are also observed in the 3D LGE Dixon images, as we can see on both water and fat images. Here we introduce an autofocus-based method for virtual 3D INAV-based non-rigid motion-compensated reconstruction that includes beat-to-beat anterior-posterior translational motion correction for whole heart CMRA imaging and whole heart LGE Dixon imaging. Minor improvements were observed with the virtual 3D INAV-based reconstruction in comparison to the 2D INAV that may be due to limited amount of anterior-posterior motion in the subjects. We plan to investigate this approach in a larger cohort of patients with coronary artery disease and wider range of respiratory motion. Thank you for your attention.